I think we are moving to our second section of the webinar, which is on acute painless vision loss. And I would like to welcome our next three speakers. First one will be Dr. Neringa Jurkute, who will discuss transient ischemic attack and Amaurosis Fugax, differentials and assessment. Dr. Rodolfo Mastropasqua from Italy will discuss artery and central artery and vein occlusions and their acute management. And finally, Dr. Matteo Forlini from Italy also will discuss Vitreous hemorrhage, differentials, and assessment. Thank you very much.
Good evening, everyone. Thank you for inviting me to give this talk in a SOE webinar series. It is important to know the terminology. And transient ischemic attack, which further I'm going to refer to TIA, is an episode of neurological dysfunction resulting from temporary disruption in the blood supply within the brain, and it's not associated with any infarction or ischemia. If there is temporary retinal ischemia and disruption in the blood supply within the retina, it causes Amaurosis Fugax, which actually this term falls under the transient ischemic attack terminology. Both cases are acute. They happen due to inadequate and temporal cerebral or ocular blood supply, last from a few minutes to a few hours, and usually fully resolves within 24 hours. Specific imaging studies demonstrate the lack of cerebral ocular infarction. 74 years old female came to the clinic with a history of painless sudden left eye visual loss, which she describes as curtain coming down. The symptoms were associated with the expressive dysphagia, and both of them resolved at the same time within 10 minutes. She had a treatment for her general condition, and medications are listed here. Ophthalmological assessment was within normal limits. Fundus examination indicated signs of hypertensive retinopathy. And transient monocular visual loss and Amaurosis Fugax in the left eye, expressive dysphagia, and likely TIA diagnosis were made. She was further investigated by stroke and cardiology teams, and a few episodes of paroxysmal and atrial fibrillation flutter were identified by Holter monitor. In addition to her previous medication, she was prescribed with clopidogrel, and since then she never experienced similar episodes of signs and symptoms. The clinical picture of Amaurosis Fugax usually sudden onset, severe and painless visual loss. It can be partial field or full field loss, usually in one eye, which completely resolves within 1 hour. Ocular examination is usually normal. An exception would be seeing the retinal emboli within the vessels. There is a normal neuro-ophthalmological, neurological assessment, and normal vision in the unaffected eye, of course, if there are no comorbidities. The origin for the atherosclerotic plaques travel to the eye can be within the eye, optic nerve, orbits, brain, neck, and heart. As I mentioned, thromboembolism is one of the most common causes and actually travels. The main source for that is carotid vessels. Other causes to lead to TIA and Amaurosis Fugax would be hyperperfusion, vasospasm, elevated plasma viscosity due to certain conditions, or atherosclerotic cerebrovascular diseases. It is important to ask patients about other comorbidities and other risk factors. Differential diagnosis of transient monocular vision loss is wide and large, but generally not all of them will be urgent and needs urgent assessment and treatment. Talking about TIA, emergent ophthalmologic and cerebrovascular relation is necessary in those cases because there is a risk of stroke following these, which varies from 10 to 15% within the first 3 months. An urgent assessment, investigation, and treatment can reduce this by up to 80%. What we can do in the clinic? Comprehensive neuro-ophthalmological evaluation with the imaging is important. Urgent bloods needs to be requested, as well as urgent MRI and MRA if ICA dissection is suspected, or if ICA stenosis is suspected, then duplex Doppler of carotids. And of course, referral to TIA clinic vascular specialist or neurologist is a must. ABCD2 score, which you can see here on the left-hand side, is widely used for the TIA risk stratification. Patient needs to be given 300 milligrams of aspirin in acute stage, which is followed by 75 milligrams once a day until they are seen in TIA clinic. Of course, patient needs to be advised not to drive till formal assessment. It is important to manage all the risk factors, and if there is a specific TAA etiology identified, then it leads to a specific management. Moorfields Eye Hospital has a TAA pathway for the urgent scenarios and routine scenarios, but due to lack of the time, I'm not going to discuss this. Probably it's going to be available later online, and this is the scheme. So take-home message. All TAA should be treated as medical emergencies as they may lead to a permanent vision loss or ischemic stroke. They should undergo extensive workup in the same manner as those with an acute stroke. And the management of all TAs is similar and should focus on the stroke prevention strategies. Just don't wait and act quickly. Thank you very much.
Hello everyone, thank you very much for the kind invitation. We know that retinal vein occlusion is the second cause of visual loss worldwide, and we can differentiate between CRVO 10-20% and BRVO 80-90%. We know that the physiopathology behind the vascular occlusion is all regarding the balance of the Birkhoff triad, which leads to vascular occlusion. Therefore, we must consider this risk factor when we try to assess a patient facing this disease. We need to evaluate the patient history, check all the systemic risk factors like blood pressure, blood test, and try to understand which is the cause behind. Regarding the CRVO, we have two forms, an ischemic one and a non-ischemic one. The first one is distinguished because the vision is normally really poor. There is a RIPD, extensive hemorrhage, cotton wool spot, and changes at the perimetry and electrophysiology. A multi-imaging approach is fundamental in order to assess this kind of patient. Here you can see a fundus photo with the most peculiar changes in case of CRVO, and the fluorescent angiography is very important in identifying this disease and distinguishing between the ischemic and non-ischemic form. We know that the ischemic type has non-perfusion areas that are greater than 10 disc areas, so we have to use it every time we study our patients. The macular edema is another key factor. We know what macular edema is an imbalance between fluid entry and exit with accumulation of intra or subretinal fluid, and the gold standard is, of course, fluorescent angiography and structural OCT. The latter is useful in identifying the type of edema, so we know that there is cystoid macular edema with or without serous detachment, but also we can have a loss of the delineation of the inner retinal layers, and this is due to the ischemia. The angio-OCT is the last tool available, but is really useful and helpful for our clinical practice. The established issues are that in case of RVO, the foveal vascular zone is enlarged, there is a dropout from the superficial plexus, and an anastomosis between superficial and deep capillary plexi. We can use OCTA also for evaluating the response to treatment. This is a nice example of response evaluated with OCTA before and after treatment with intravitreal dexamethasone for non-ischemic CRVO. The treatment, if we have a non-ischemic CRVO, with a good vision, we can watch and wait, but we need to be ready to switch to therapy if there is a change to the ischemic form. If there is a bad vision or macular edema, we should consider treatment with anti-VEGF as first instance or steroids as a second instance. Regarding the laser grid for non-ischemic form, we should use it if there is no response to VEGF treatment, but we must use it for CRVO of the ischemic form because this guarantees us to improve the blood supply to the perfused areas and reduce dramatically the risk of neovascularization complications. The retinal artery occlusion is a different disease. We know that the pathogenesis is due to embolism or high cholesterol liver or thrombophilia, vasculitis like Orton, or autoimmune disease like Susak, and all the other risk factors for embolism. We have 4 different clinical patterns, basically non-arteritic with or without ciliaretinal artery sparing, and arteritic. And here you can see an example of the 4 patterns. Again, it's mandatory to take care of the systemic risk factors. Otherwise, we cannot help our patient. But in these cases, the treatment is much more difficult because we don't have time. So the fluorescent angiography helps us in distinguishing between the non-arteritic and the arteritic CRAO, as well as the structural OCT, which can give us in the early acute part of the disease and hyperreflectivity, and in the late chronic part, atrophia and hyporeflectivity of the inner layers. The OCTA is very important and sometimes is able to identify the area of non-perfusion better than fluorescent angiography. And here you can see, for example, an example of Susak with the complete restoration after treatment, and you can see how the OCTA was helpful. Regarding the treatment, of course, we don't have time. We need to reduce the pressure, so anterior chamber paracentesis, or trying to do ocular massage. If there is an orton, we need to give systemic corticosteroids, temporal artery biopsy, and treat the risk factors. Thank you.
Hello everybody, I'm Dr. Matteo Forlini, vitreoretinal consultant in San Marino Hospital. My SOI webinar is about vitreous hemorrhage, differentials and assessment. Of course, the main symptoms are sudden painless vision loss with haze in the vision, and also myelodysopsia or floaters or photopsia. About signs, you can see red blood cells in the anterior vitreous chamber, a partially obscured view or a totally loss of red fundus reflex if severe vitreous hemorrhage. In case of chronic vitreous hemorrhage, you can see yellow ochre appearance, and you can see also a mild RAPD if it's a dense hemorrhage. About etiology, the most frequent causes of vitreous hemorrhage in adults are proliferative diabetic retinopathy. This is the most frequent cause at all. Or hemorrhagic PVD with retinal tear or retinal detachment, retinal neovascularization. Another cause could be trauma or Terson syndrome, or another cause rupture retinal microaneurysm or retinal angioma. A very useful mnemonics for vitreous hemorrhage differential diagnosis is the word vitamin D. You have to remember vitamin D, V as vascular, like hypertensive retinopathy or sickle cells. I as ischemic, like neovascularization post-central retinal vein occlusion or branch retinal vein occlusion. T as trauma, Terson or Valsalva. A as autoimmune, like for example occlusive vasculitis, like Ehl's disease, for example. M as metabolic, as proliferative diabetic retinopathy, of course. I as infectious, like infectious vasculitis. N as neoplastic, for example, leukemia, lymphoma, or melanoma, or radiation retinopathy. And D as developmental, like ROP, incontinentia pigmenti, or Norris syndrome. About etiology, don't forget the following causes in children. You have to think about child abuse, for example, shaken baby syndrome, or pars planaris, or X-linked retinoschisis. It's important to make a differential diagnosis with vitreitis, and you have different clinical features. First, you have a not sudden onset. It can be associated with anterior-posterior uveitis. You can have white cells in the anterior vitreous, and you have to look for snowball or snowbanks. At US features, you have a more uniform echogenicity. You can see uveal thickening with pars plana exudates or cyclitic bands, also vitreoretinal adhesions or tractions. About management. First, patient's history. You can ask for any ocular or systemic disease, maybe trauma, maybe anticoagulants. Then, slit lamp examination with undilated pupils, considering IOP, iris neovascularization, or RAPD. Then, dilated fundus examination of both eyes, and if not possible retinal examination, you have to perform B-scan, of course, to rule out. So maybe you can find retinal detachment or tractional retinal tears or intraocular tumors. About treatment, if there is evidence of retinal tear with retinal detachment on B-scan, or in case of vitreous hemorrhage with iris neovascularization, or in case of hemolytic or ghost cell glaucoma, you have to perform vitrectomy. But if there is no evidence of tear or retinal detachment on B-scan, you can choose for close observation, suggesting to the patient no heavy lifting, no bending, no straining. Keep head of the bed elevated. It's better to eliminate anti-clotting agents unless medically necessary, and you should evaluate patient daily for the first 2 or 3 days. But again, if there is no non-clearing vitreous hemorrhage or if etiology remains unknown, you will have to perform vitrectomy as well. A complication can be ghost cell glaucoma. It's a secondary open-angle glaucoma caused by hemolyzed erythrocytes obstructing the trabecular meshwork following vitreous hemorrhage. The diagnosis is made by history of vitreous hemorrhage with IOP markedly elevated and anterior chamber or trabecular meshwork filled with small circulating khaki-colored degenerated blood cells. You can see all that with gonioscopy. And about the treatment, you can use aqueous suppressant agent or glaucoma surgery with or without vitrectomy. Thank you for your kind attention.
Thank you, Neringa, Rodolfo, and Matteo, for these very nice presentations. And now we will have a chance to discuss and take the questions from the audience. There is one question to Dr. Neringa, basically. So the question is, should I prescribe something else in the emergency room in addition to aspirin to a patient with Amaurosis Fugax, the TIA, etc., if we have a case where the patient has 2 hours to travel to the bigger medical center?
Well, the protocol would be just to give 300 milligrams of aspirins until he or she is being seen in TIA clinic, and omit even regular antiplatelet treatment if the patient is already on that. If they are already anticoagulative treatment, then continue this. There is no need to give aspirin, and that's it.
Okay. Any questions to Dr. Neringa? Simon, are you?
Yeah, I think there's a second question in the audience that was for Dr. Forlini. I think it's particularly about the retinal tear that was presented in the photograph. Would you like to comment on that, Dr. Forlini?
Which photograph you said?
So, Dr. Matteo, from the audience, they're asking you to show the tear that was obvious on the ultrasound, which may not be so convenient now I'm not sure if you can show it right now, but maybe later on we can email him. His name is, the audience is, we will email him later on with the sign on it.
Okay.
And there's another question for you also. So the question is, how long is it necessary to wait before performing a vitrectomy in a case of vitreous hemorrhage? This is for you, Dr. Forlini.
Okay, good, very good question. So talking about vitreous hemorrhage without retinal detachment, of course, okay? So
yes,
the question is, if I have a vitreous hemorrhage persistent with a flat retina, usually I'm waiting maybe 1 month, maybe the second month, if I don't see any improvement in the second month, even with the medical therapy like FANS drops, non-steroid drops, if I don't see any improvement after 1 month, the second month, I'm considering vitrectomy.
Can I ask to Matteo something?
Yeah, ciao Rodolfo.
Please,
Ciao,
please,
Matteo.
please.
Matteo is a very good friend of mine. A question: if you see a retinal tear with the ultrasound, you go straight to theater, or you just monitor so you know that there is a vitreous hemorrhage with retinal tear, but not enough view to perform laser. Do you wait few days strictly monitoring with the B-scan, or you just go in and remove the gel and do the laser?
I would wait 2-3 days, because sometimes in 2-3 days I could obtain a good visualization to perform the laser. And of course, it's better to perform laser
and avoid the vitrectomy.
Avoid vitrectomy. So in the best hypothesis, I could wait 2-3 days. I could have a good visualization to perform laser, and that's it.
Sure.
And retina remains flat. This is the best hypothesis. Of course, after in the worst hypothesis, if the retina detaches, I have to go to vitrectomy.
Sure.
So it's just an attempt to save from vitrectomy. Yeah. Do you agree?
No.
You agree?
Yes, I do. Even though there are some centers that approach hemorrhagic PVD with retinal tear as a macula or retinal detachment, so they go straight. Whereas in crowded hospital or busy hospital, they do what to do, which I agree. Maybe if you can avoid the vitrectomy, it's better.
I agree. Vitrectomy is, of course, invasive treatment.
Yeah.
So I have one question for Rodolfo, kind of like a segue on it. So trying to be less invasive these days, people are now switching over from fluorescein angiogram to using OCT angiogram. So, in the era of, current technology now, is the fluorescein angiogram still useful in retinal vascular occlusion, or have you all now completely used OCTA instead?
Nice question. So the guideline says that we, as a first approach, we have to perform fluorescein angiography, which is still the gold standard. But we can follow the patient with the OCTA, which is quite good, as I showed, in determining the areas of ischemia and also in seeing the response to treatment. But also because the wide field of CTA that we have, they cannot arrive so peripheral as the fluorescein angiography. So at the moment, a wide field for FA is still the gold standard.
Thank you so much.
Thank you.
Thank you.